is our next speaker, Rajan Puri, who's the clinical associate professor at Stanford, and his work that he's been performing in terms of helping Stanford rolling out tools to protect the health of their campus and to be able to screen. So I'll open it up now to Rajan.
Okay, thanks, Brian. Hopefully you can see my screen.
I can.
Okay, great, perfect. Well, thanks so much. Appreciate the invitation, Steve, Brian, and others. My name is Raj Puri. I am one of the occupational health physicians here, Director of Strategic Health Initiatives and Innovation. Little did I have any idea, and that title came before COVID, did I have any idea how much of an impact I would have to implement, I think, within Stanford. So what I'm going to talk about today is health check and then dashboarding, essentially an automated surveillance tool for COVID, or tools for COVID, and specifically at Stanford. Before I get into that, I'm going to talk about Workplace Health Innovation Lab, and I'm the director of this lab, otherwise known as the Wheel Lab. And this is what we created pre-COVID. It's essentially a newly launched innovation, multidisciplinary research laboratory focused really around the realization of new and innovative novel ideas within Stanford regarding total worker health. And so mainly related to employees. And so I'll just move on here. We have a few goals, and one of them, again, was the improving total worker health, so centered around employees, because that's what occupational health is. So occupational health is a specialization within medicine, and I am faculty within the Department of Medicine, and it's a real interesting niche. What we wanted to do with this lab also is to just create and solve real world problems that may improve an employee's job. So how is it going to really impact a person while they're coming about? And that could be anyone. So we serve and take care of the needs of employees, not for their personal, like we separate ourselves from the primary care health physicians or PCPs. But if you've been injured on the job, or you have had an exposure because you've been doing a research lab experiment, or what have you, you could be golfing and the golf cart basically hits you, and then we're going to take care of you. Those are some of the things that we do, and it can be any sort of gamut of employees while working at Stanford, from janitorial, custodial, to faculty, research faculty, any sort of employees working at Stanford. Other things are basically, our goal is basically to generate some sort of societal impact to overcome workplace inequities through a bunch of grassroots participants. And that includes the line, entry, staff, and non-management levels. And so I think that was our initial goals. Those were our goals before COVID. Now, what I want to get into, and so that kind of ties into health check. And so the outline of this talk is really going to be talking about health check automation. Before I get into that, I'll talk a little bit about the COVID statistics from beginning to present. What is health check? I keep saying it, but I've said that it's an automated sentinel surveillance tool. I'll talk more about that and demonstrate a little bit what that looks like. Key components, and then integrated into the health check automation is also dashboards and metrics, because of course everybody would want to know that, and particularly surrounding COVID. I've been at the forefront of COVID since January 1st. In fact, I've taken actually no vacation, and I've been coming into clinic every single day, and that's where I am right now. So it's interesting because I can definitely see the impact of what's been happening since January of last year. But again, the dashboard and metrics are integrative metrics to clinicians, employees, and students in HR. And then just seeing the trajectory of COVID at Stanford, and not just at Stanford, but also outside of us. And then other uses for health check in terms of a vaccination status. That's our new thing that we're trying to do here. But I'm going to backtrack for a second and tell you about COVID statistics. This is from March 6th of last year. This is when we really started tracking COVID in California, within the United States, and how it was sort of impacting. I took this is a snapshot. At the time, there were really no databases around COVID, and the only one was the Johns Hopkins one. Now you can see it all around in media and other websites. But this was really dramatic. At the time, I took this snapshot because the day, I think that the afternoon of, I was doing a lecture at UCSF. And what I showed them was this picture. And at that time, the total confirmed positive cases of COVID was 100,000. It had just hit this this number. This is an actual snapshot at that time. As you can see, mainland China was 80,000 at the time, and we were way down here in the United States, 240 cases. That was not, it was significant, but it wasn't as dramatic as it would have turned out to be, as we all know now. You can see this heat map. I mean, this bubble essentially shows everything in China hitting then Europe, and not so much in North America or the US. I mean, in fact, when I was walking around, some of my colleagues said, do you think this coronavirus, it wasn't even called COVID at the time, do you think this new virus, this novel virus is even real? Do you think it's going to do anything to us? And I said, I think it's pretty real. And I showed this at a medical conference, this slide, which is, I think, pretty dramatic. And it was not even related to COVID. Now, fast forward about 6 months, this is another snapshot I took of the Johns Hopkins dashboard, July 29th. So you can see I started out with dashboards. July 29th of last year, boom, we went from, again, 100,000 cases to 17 million cases very quickly. And you can see all that red has just gone away. And from Asia, for the most part, because they did really great mitigation efforts and prevention and other things. And then Europe also was winding down a bit. And then obviously in the United States and then South America, we just bubbled up dramatically and we became #1. So with 4.4 million cases, US led went all the way up to the top. And then Brazil, India, Russia, South America, and others were closely behind. And then fast forward to a few days ago, this is the bubble map. Again, went from 17 million to 120 million cases. I'm just giving some perspective here. And we're still at the forefront of the number of cases. And we continue to see a ton of cases on a daily basis and a ton of cases of deaths and hospitalizations and other things, though we're on the trajectory downwards because of vaccination. So we're at 29.5 million in the US, and Brazil and India and Russia are all still kind of very similar in that trajectory or in that alignment, I'd say. And the global deaths is 2.6 million. So you can see the issues. I want to then talk about Stanford Health Check, but I want to start again, backtrack again to this one slide. Right even before this in January, February, I've been tracking COVID since January of last year when I first started hearing about it, and then February. And then it was really around February when I realized it's going to come to Stanford at some point. It's going to come to California. It's going to come to the US. It's going to come to Santa Clara County. And lo and behold, we got to do something. What are we going to do about that? As an occupational health physician at Stanford, taking care of employees and other folks, what will we have to do very quickly? And I figured, I didn't think it was going to go to 120 million cases globally or 30 million cases, but I knew it was going to have some sort of impact. So we created this Stanford Health Check. Basically, and I'll show you what it is. The key objectives of Health Check is basically, and this is not off the shelf, we didn't buy it, but we created on the platform of ServiceNow. So ServiceNow has a sort of platform, but it was never used or meant or have any purpose for what we did, actually, in fact. So again, the key objectives, the first one was to identify COVID cases at an early onset by automated self-reporting. So people basically come in, before you come in, you do health check, you report your symptoms, you report any exposure you might have had, report any tests that you might have had, and then travel. And this sort of went in order. There was no testing, no significant proper testing that we could do very quickly. We didn't have it on at campus so fast. We had to resort to the hospital, and travel became other issues as well. The second objective was to decrease the time lag in communication between our initial notification by employee HR and occupational health. And the third was really just, again, automated notification based on our own program medical logic. So we as physicians programmed it into the system to instruct employees as to what to do if they're sick, if they're positive, to either quarantine or isolate. And that response time, instead of calling us and doing a physician encounter on the phone or in person, they would just get an automatic program logic. Within 5 seconds, you just get into the system and then boom, you know what it is. So, and then this is where it is. If you're a Stanford employee or Stanford student, you have access to this. It's healthcheck.stanford.edu. You have to do a single sign-on before you get into it. So if you're not an employee or you're not a Stanford affiliate of any sort, you can't use it right now, but I'm going to demonstrate what it looks like. Again, we officially launched it in May 22nd. We actually did a pilot even before that in, I think, the first week of May at SLAC, Stanford Linear Accelerator, who also uses it. It's required. And in terms of who's actually using it, all faculty, staff, and students and postdocs are required to submit this daily. And it's integrated into our Stanford mobile app. So you can do it from your phone, you can do it from your desktop, laptop, et cetera, et cetera, et cetera. And we program the medical logic strictly basically, like if somebody encountered or talked to me, I would tell them based on whatever their symptoms are to stay off for a variety of different days. And so you could get a green check or 1 day, 3 days, 7 days, or 14 days off, all the way up to 14 days, sometimes even longer, depending on your symptoms. As you can see, so the 7 and 14 days were the most critical because you might have very mild or severe symptoms or moderate to severe symptoms, or just COVID positive. If you're COVID positive, we would have put you off for full 14 days. Since then, we've kind of dampened down a little bit of that. I'm going to show a 3-minute video here. I think this is actually probably has the most impact of what health check is. So I'm going to press play here and hopefully you can see that.
The Stanford community has responded with extraordinary understanding and resilience in this time of rapid change. Through social distancing and other preventive measures, we are all doing our part to help slow and reduce the spread of the COVID-19 virus. As we continue efforts to protect ourselves and our surrounding communities, we ask that you participate in the Stanford Health Check program to prepare for a safe return to campus. Stanford Health Check is a quick and simple daily assessment of your personal health that you submit through an easy-to-use online tool. Participating will only take 1 to 3 minutes and even less time after you initially fill out the form. Here's how it works. Go to healthcheck.stanford.edu. Answer a few yes or no questions about your experience with COVID-19 symptoms, testing, self-isolation, and exposure. If you answer no to all questions, you'll submit the assessment. If you respond yes, we'll ask for a few more details. Do you have COVID-19 related symptoms? If yes, we'll ask about when the symptoms started, how severe they are, and what they are. We'll ask you to check the box next to the symptom you're experiencing and if you've had contact with anyone else. Have you been tested for COVID-19? If yes, please enter information related to your most recent test. Are you self-isolating or avoiding close contact with individuals inside or outside your home? Indicate where and when you started self-isolating. Next, we'll ask if you've had close contact with someone with COVID-19 or COVID-19 symptoms in the last 2 weeks, and for information related to the exposure. The final fields on the form ask for the last date you were on campus and which building. When you're done, select Submit Self-Report. The system will immediately let you know if you're cleared to be on campus that day. In some cases, you may be asked to stay off-site for 1, 3, 7, or 14 days. The next time you log into the Health Check tool, the fields will be auto-populated with your previous answers. If you experience any health changes, you'll only have to edit the corresponding fields before submitting again. The information you provide benefits the health of the entire Stanford community today and will guide our future efforts to stay ahead of illnesses like COVID-19. Stanford recognizes the sensitive nature of COVID-19 questions, and we take the privacy, security, and confidentiality of your information seriously. Your participation in this survey will remain confidential and shared only on a need-to-know basis. Thank you for helping Stanford to advance the well-being of our community during this time. Every effort matters. For more information about COVID-19 and Stanford's response to the pandemic, go to healthalerts.stanford.edu.
All right, so I'm just gonna, so hopefully that was a good, decent overview, but it's pretty high impact, I think, as to what it does, why we're doing it, et cetera, et cetera. So what was our overall approach for health check? I mean, so I showed you the health status, basically self-reporting. It's a self-attestation. Automated reporting, it says data not approved yet. It's been approved for several, for a long time, basically, since we launched it. So that's outdated. But then compliance management and analytics. And so those, certainly the analytics point was very important. We would educate and verify people, or whether or not they're compliant, making sure that that's actually happening. So we implemented Wi-Fi and other things actually to make sure that we knew that people were actually doing it. And then policy enforcement. There's a lot of policies that we had to implement surrounding health check. So it wasn't the easiest thing, but we eventually did it. And then exposure notification, otherwise known as contact tracing. So we also implemented that as well. So our OHC basically means occupational health. And then VADEN is basically the Student Health Services Center. And so basically we contact positive people and severely symptomatic people, anybody who's essentially red badged. And then we report it out to the county. at least anybody that's positive, and that's a requirement. And then over here on the left is, as you saw, is basically a green badge. So we have a badge on somebody's phone. You can be turning green or you can be turning red, depending on your symptoms and status and other things like that. And then this is interesting. We moved from an educate. So we started out here in this diagram. We started an educate and trust. So we're telling people, teaching people as to how to use it, which was actually pretty good. It was there's a lot of strong momentum, and everybody was very much in favor of doing it. Then we moved to trust and verify, and then thirdly, verify and enforce. We actually, enforce is kind of a tricky thing, and there was discussions as to, should we, if people don't do it, what should we do? Should we then lock them out of their computers? Should we then not let them in their doors or their offices and things of that sort? So there was discussion about the enforcement as to how to do it, or just do a gentle enforcement, in fact. From the employee aspect, we turned this into, well, for the entire campus, anybody who had to come in, we turned it into a mandatory thing. But we never really enforced the aspect of using health check, at least for not the employee side of things. On the student side of things, a little bit different, but we're still underway, and things can change at any level. But this is sort of like, this is the illustration where things can go, and I think it's really a sliding scale. It can go back and forth depending on how COVID changes or doesn't change. On the back end, I'm going to move into a little bit of these, into some of the back end things and some of the metrics. But you can see here, this is basically what the back end looks like. We have all these numbers in terms of the university employees, Slack, and then students, but not postdocs, and then what it actually looks like. So we have really great diagrams, images, and other things, whether somebody's healthy, recovered, exposed, positive, or symptomatic. And I can't say what date this is from for privacy reasons, but we turn this into a red, yellow, and green status badges. And then also symptom severity, very mild, moderate, severe, and so forth. And even temperature checks. Early on, we didn't require temperature checks, but we implemented and asked people to do a self-attestation about their own temperature. And since from then, we actually went away from that unless they're symptomatic. So this, now to move into a little bit into the dashboards, which are really integrated into the health check. This is a public, and this is a public-facing dashboard. So you can see this right now. If you Google Stanford COVID dashboard, this is the first thing that will pop up. This is divided into students, as you can see here. And then this is all this here is basically, these are the tests. So we implemented tests, the testing regimen, and we started pretty low from June. You can see the numbers of testing very low, 500, 900. And then August, starting at the end of August, we implemented this. We partnered with another testing platform company outside of Stanford, and we just escalated the numbers. You can see from 1,000 to 3,000 to 5,000. And then Thanksgiving hit, and so obviously when people are not here, they're not going to test, and we dropped down. But then just after the new year, January 4th, we implemented more regimented testing because of travel and other things. More stringent testing was implemented and enforced, in fact. And so you went up to 8,000. So we went from 1 to 2,000 up to 8,000. Now we're almost at 12,000, including to the most recent week. The positivity rate, interestingly, for students have been actually very low. So less than 1%, less than 0.5%. This is 0.1. It's not an error. It's an actuality, to be honest. And those are cumulative tests conducted. And then in terms of employees, staff, faculty, and postdocs, almost similar. I mean, almost equivalent, 0.15% positivity rate. So very, very low. And then tests conducted also. You can see the numbers. As we implemented testing, the numbers skyrocketed. We went from like these into the hundreds to thousands, a few thousands, and then up to 8,000, 7,000 to 8,000 numbers. So most recently, we've hit that. And what I should have mentioned also earlier is that the red numbers here are basically the number of positives. So each on a weekly basis. So 4 last week, the 4 the week prior to that. I mean, it's pretty low now, but we did hit almost a high around January 4th that week of 28 on the employee side. Let me back this slide again, and then 54 on the student side. So that the red again are the positives. That's pretty dramatic, and it was kind of scary at the time. And then in the last week, actually, we had 0 students testing positive. So that's, if you're looking at trajectories, I think that's pretty good. We haven't had 0 students being positive since around Thanksgiving, November 23rd that week, actually. So everybody's very encouraged and psyched about that. And then I'll move on to other metrics. How many surveys are we actually getting with health check? And so all of this stuff is all very, very well integrated, as I mentioned. 375,000. That's sort of a minimum number. We actually had much more, I think. That's the student side. On the employee side, we'd had 900,000 because we first had it mandated for employees and then students. So we've had well over 1 million health check surveys all across the board, which I think has been pretty great. And move in a little bit into the into vaccines, and so and health check and other things. What you can see here is this is actually what's happening within the United States. So 2.5 million doses per day is actually being administered. We started out very low in December around Christmas time. In fact, actually, I've been fully vaccinated since January 12th. I got my first dose here at Stanford within the hospital just a couple of days before Christmas, and then I got 3 weeks later the second Pfizer dose early January 12th. And so you can see what's actually happening. It's a significant jump in 2.5 million doses, but the threshold really is 3 million and 4 million. We really need to get into that, but we're not there yet. What is the trajectory? This is the model. This is a model for vaccinations. And so at our current pace, as of like yesterday, basically 22% of the population has at least gotten one dose of either the Pfizer or the Moderna vaccine, or has actually gotten the only dose of the Johnson & Johnson dose. So 22% so far. I mean, it's not great, but it's certainly, I think, better than we anticipated. So it's escalating. By May 4th, it's projected that we'd have about 50% of the population, so at least getting one dose of the mRNA vaccines, which is Pfizer, Moderna, or at least one dose of or at least the only dose of the Johnson & Johnson, and then hopefully 90% of the population by August. But that may be a little bit too ambitious, but I mean, I think that'll be brilliant if we can get anywhere near that. And I think there's discussions as to what that's going to look like. In the last, I think Addison was mentioning trajectories and what's the next couple of months are going to look like, and even November for conferences and other things like that. And I put this slide up to show that could be the trajectory. If people are getting vaccinated, that could bode well for conferences and other things. I think even the cruise lines and travel industry are just really not doing well, especially the international travel industry. And I'll get into a little bit what could happen with that. Variants, and I mentioned a little bit about the variants, and we're tracking this too, but this is actually what's happening at Stanford. And on the left column here are basically the different variants: UK, South Africa, Brazil, and then California variant. And the third column is the number of variants that we've actually screened at the Stanford Hospital, which I think is really interesting. This is not widely known information, but you can see here that we've had 21, or presumptive in parentheses is presumptive. But you have 21 at least UK variants that we've screened so far. So basically, somebody that's turned positive, then gets screened by the virology lab, and then we get what it looks like. The reason is because some of the variants are, as most folks know, is more transmissible and can be more deadly. So 21 UK, South Africa, it's only 3. The vaccines are actually not doing a great job against the South African variants, but fortunately, we've only had 3 come through our hospital, and then nationally, it's just not a lot anyways. So that's still a worry that it can get out of hand. Brazil is about 10, and then this is the most, and it's really this California variant, 32 and 1075, over 1,000 that are presumed to be the California variant. There's a 20% increase in the transmission rate with the California variant versus the original virus itself. So that can be problematic as well. But the antibodies are showing to be helpful. There is a decrease, or sort of what we call an immune escape, where they escape the vaccine by the antibodies. There's a recent study, I think just came out yesterday, the day before, from UCSF, showing there's a 2.5-fold decrease in the antibodies if you contracted the California variant. At least from the current vaccines, and then six-fold decrease in the antibodies if you contracted the South African variant. So kind of worrisome from that perspective. But so far, I think the vaccines are doing a good job. So what are we doing itself from the university perspective, and then also integrating that into health check? We created our own appointment scheduler. So if anybody on the call has gotten a vaccine themselves from CVS, local pharmacy, or their own other provider, Kaiser, Sutter locations, or other local hospitals, the county, et cetera, there are different types of schedulers out there. So what we decided to do is another novel thing. We created our own appointment scheduler to reach out to people within the Stanford community and making it super, super easy. So the way you log into this, it's basically just selecting an appointment. Right now, there's a shortage and there's a limitation in the number of appointments for vaccines within the Bay Area in general, and then certainly within Santa Clara County. So that's kind of a problem, but we hope that will increase in the next 4 to 6 weeks. Either way, you can still reach out to your local pharmacy and hopefully still get one, or even Kaiser. But we created our own. This looks very simple on the front end, but complicated on the back end. And anybody who has a Stanford University ID can basically log in. And we created our own invitation as well. So we literally sent out invitations to select people that we thought might be at higher risk levels because they're front facing, they come onto campus and they may be working with other people. And so just in general, more exposed. So we send out thousands of invitations to people within Stanford University and encourage them. We're not mandating it right now, but we encourage people to get the vaccine. And so again, this appointment schedule is about 100 times faster than the local pharmacy schedulers out there right now, because if you have a Stanford University ID, it recognizes your name and then other points, but you can quickly make an appointment. Again, that's only for people that have received an invitation. So that and the vaccines in general are free of charge. There's no charge, fortunately, for them. So we're very happy with that, and it is in partnership with the hospital, fortunately. The other thing here I'll show you is what we're trying to implement is a supplemental question within Health Check. So I showed you the other aspects: symptoms testing, buildings people walk through, and exposure, and then travel. But also the vaccination. So this is another category that we're trying to get into, is the vaccination status. Now, we've done some polling and benchmarking with other universities recently in the last couple of days to see our other universities, Ivy Plus universities, or peer institutions also asking for that. And it's a big subject of debate right now, whether or not it should be mandated, where it should be optional. Right now, we're hoping that we can put this question into Health Check. So it's a simple question, although there's quite a lot of conversation about it, rightfully so. And so, have you been vaccinated for COVID-19? And right, this is going to be changed, but this is just a mock-up is what you're seeing. It's not in Health Check yet, but this is probably the most, I think, controversial aspect of implementation of this data point within Health Check. Because people are worried, what can you actually do with the vaccination status information? Who's going to have access to it? Can you integrate it with the other aspects of the data within Health Check? So Health Check is the center and corner and central theme within for prevention and mitigation of COVID at Stanford. So I should say that. And I think it continues to be that way. So again, this is a simple question, and asks that yes or no. And if you say yes, it asks you vaccine manufacturer, whichever. We have all the manufacturers there. I think even we're going to put Sputnik in there as well, because people travel at different locations, and then the AstraZeneca as well, because that's the Oxford vaccine that's given in a lot of places in UK and other Asian countries. And then the dates, as you can see. So that's helpful, we think. Other things that are on the horizon, I'd say, with relation to COVID vaccinations is this. This is just coming out. There's a big vaccination conglomerate, or basically consortium, that's working with each other to figure out how do we create a sort of passport or immunity card. And you've probably heard it and read it in newspapers and other things. But what is the status of that right now? I'd say, so what you're seeing here on the left is a QR code, obviously. And it specifically asks you or records your vaccination status. So here's dose 1 is Pfizer, lot number, in fact, the date that you got it, and then which location. Here it's Walmart. Walmart didn't create it, but they partnered with the Commons Project Foundation, and this is called Common Pass, and they're the ones who developed it. They're also partnered with Health Pass, which is developed by Clear. So folks that have done business travel or any sort of travel know Clear, because you can streamline and then get past a fast track when you're going through the airport at the security gates. And so it uses biometric technology to confirm people's identities at the airports. And then right now, JetBlue, in fact, JetBlue and Lufthansa are already using Common Pass to verify passengers' negative virus test results before they can board certain flights. And then EU also is doing something like this, a green digital certificate for people, and that could integrate testing, recovery status, and then also vaccination status. And so that's a lot of high level of debate that's been ongoing for some time, and now really escalating. What can you do with that? And so I think the EU basically wants that pass to get passed through, so that way you can travel within the European Union, unobstructed amongst any of the countries. And then one other thing they've mentioned is that if you use the Common Pass app, they're trying to give you some fringe benefits. One of them is to basically have an exclusive lounge entry into some of the airlines that are using it. So I'm just bringing this up because I think it's certainly interesting. And we thought about doing this as well in health check. We have it incorporated into our mobile pass, into people's phones, so that you can do health check on your phone. But also, if we are allowed to get data gathering of the vaccination status, we can also create a QR code. We can do other things like that. And then potentially airports or airlines might be able to use that as well. I don't know that that would be the case yet because it's just for Stanford. But if there is just one central data point or one central location, including Common Pass or Health Pass, I think that's really great. So a top-down approach where it's universally accepted would be probably the best bet, rather than a sort of piecemeal from different universities then doing their own thing. I don't know that's the best thing, but that might also happen as well. And then just kind of summarizing here, again, health check. It's proven actually to be the centerpiece for COVID prevention and mitigation at Stanford. Again, I started thinking about it in January, February. Fortunately, there's a lot of collaboration surrounding health check. It wasn't the easiest thing. I mean, it was, and I would say it was basically like a startup. It ended up being like a startup, though I don't get any money from it. And it became a Stanford project, and it cost a lot of money to do it, and a lot of FTE or hours from people to just drop what they're doing and then help us with what we wanted to do. And we're very thankful for all of the collaborators within the university. And then we also got lots of input and other folks from outside of the university as well. I had people emailing me from Australia, Canada, New Zealand, in fact, and then Asian countries when they heard about this, about how do we get this. So at the time, it was extraordinarily novel, and I still think it is, though other universities have then also developed their own sort of aspects, their own sort of like symptomatology surveillance tools. But the advantage that we have is that we created it very early. We also have basically full-on control of what we write in the questions, how we want the automation to be, the trajectory of it, how quick it can be. All these different things are just at our fingertips, to be honest. So we have a lot of control as to what we can and won't do, I guess we could say. And a lot of those obstructions have really gone away, and I think that's really beneficial. So I think, other places will say that we have something similar, but they have mostly, some of these places, or institutions or other companies have attestations, for example, which just says, well, do you have any symptoms? And people just check off no. Ours, as you saw from the variety of different questions, is much more in depth and helps us to give a more tailored approach to COVID. The other thing is that, again, it's still one major component in the battle to fight COVID. We haven't ended COVID yet. We're hoping that it will, with more and more vaccines under the front. We hope that'll be the case. I think AstraZeneca will be coming to the United States probably by April, or at least be approved by April in an emergency use authorization status. And then also the Novavax. There's another company called Novavax that are also probably come in maybe May or July, depending on when they finish their phase 3 trials. And then again, compliance with public health authority mandates. So CDC, state and county authorities. We're always we've had a lot of communication with them. In fact, actually in January, February, this is where I started communicating with CDC, and I asked them, do you have anything like this? And they mentioned they didn't have anything like that, but they were happy to collaborate. And so, we continue to collaborate with the authorities, the public health authorities, and I think that's really important. We don't want to just be singly on our own, but we also want to be ahead of the game. And I think that's the whole point of health check, is to being ahead of the game, automating everything. In fact, I'd like to automate pretty much everything, even when COVID goes away. So future uses are still in discussion, but we don't know when the next epidemic or the next pandemic is going to be. So I'm hoping health check still stays with us, and so potentially we could use it for return to work purposes or other things in the future. Even just in a sort of a general medicine sense, when people come in and they're injured or something, we could potentially automate what they should or should not do. So there are a lot of different things outside of COVID, which is why I didn't specifically say COVID in the name, but I titled it health check. So we kept it that way so far for in the hopes that we could potentially use it for other future uses. And still, it's not a substitute for social distancing, washing hands, and then wearing a face mask. But it's just another point of, a point in our arsenal, I think, so far, and we're very thankful for that. And I think, again, a virus-free zone, we're hoping that that still remains the case, but it's still here, COVID, and happy to answer any questions. Thanks. Sorry, I'm not sure that I hear.
I think Brian is probably trying to unmute himself.
Okay, okay.
You know, I just realized I'm double muted. So fantastic. So first of all, I just wanted to thank you, Raj, for that presentation, and that it's not very easy to put an app together of that kind of magnitude and in such very challenging time. So I applaud yours and Stanford's efforts on getting this off the ground. And obviously it seems like no one else really has something like this, and is you folks are leading the way and kind of showing what's needed to be done. So I congratulate you on this. In terms of the question that was asked, it was early on in the presentation, so I'm kind of struggling with this, and maybe Ozzy, who wrote in this question, can help me here. But he was curious on what tool was used for creating that dashboard, and that I'm kind of struggling to figure out which dashboard in particular he was mentioning.
Yeah, I think what he was probably, maybe, yeah, I don't know either, but so one of the dashboards was the public facing dashboard, COVID dashboard. We used Tableau for that dashboard. So that's the one with the metrics that we show for both, that I broke down into students and employees. And I think maybe that's, and we had to figure out which kind of platform we would use, but Tableau proved to be helpful in that regard.
Okay, and Steve, you know, did the high performance computing facility help on some of the back end work here with Raj? You know, how did Stanford Computing play a role in here?
We didn't specifically. I'd love to collaborate with Raj in some meaningful way.
Yeah, I think one of the things that just came in chat while I was also thinking about this was, you know, are there some insights where HPC and AI can help in the back-end processing of these types of applications?
Well, I'm certainly, yeah, always happy to collaborate with Steve and other folks with that. And I certainly think, AI can certainly help. I mean, I think we had to do our own programming and logic, and in the future, we could implement some of the AI aspects of things. I think that would be helpful. In fact, actually, we're doing a symposium. I'm co-chairing a symposium on AI and healthcare next week. So that'll be kind of interesting to see. It's an international symposium with people from all around. But yeah, I'm always happy to work with others and collaborate on a mission that we're all trying to do here.
And that was it question wise. Just a lot of good kudos. That this was just some great information, and definitely thank you very much, Raj, for presenting and being our closing speaker.
Sure, my pleasure. Thank you.
Yeah, thank you, Raj.
Sure.
Yep.
So Steve, we've reached the end. We've done it again. Any words?
I mean, other than I'd like to thank everyone for attending, and of course, all of the great presenters, and just send out the reminder that this is an end user community. And that's one of the main reasons that I've continued to be involved in it throughout the history of the HPC and then now HPCAI Advisory Council. So if you're ever interested in presenting at any of these conferences worldwide, Stanford is just one of many. Make sure to keep an eye out for announcements of conferences coming up. Visit the HPC Advisory Council website and submit your talks because we'd love to hear from everyone and anyone involved in the community.
And Addison, as our analyst in residence, we obviously with this year, a lot of our presentations focused around COVID because that is the topic of the times. What is your prediction will be the topics for HPC Advisory Council Stanford 2022 conference that folks can prepare for now?
COVID.
COVID. Okay.
COVID, also AI, and experience with new types of processing elements. I think we'll start to see a lot more. People would really like to see what experience people are having with different types of accelerators, with ARM processors, with the diversity of options that are out there. I think that makes it even more important for end users to be able to be willing to share their experiences.
Yeah, no question, especially as more people get their hands on Fugaku, right? So thank you. Thank you everyone for joining us over these past 2 days. We've really enjoyed having you here. We've really enjoyed having all of our presenters. Look for the coming days to have all these slides and replays available on the HPC Advisory Council website, on the agenda page of the Stanford microsite, as well as on our dedicated YouTube channel. Once again, I'm Brian Sparks. Thank you for joining us. Good day.